Hey, Cam followers, we're back. We have a busy week. I'm sure that you watched yesterday, which was absolutely fantastic, with the amazing Dr. Jennifer Brown talking about digital osteoarthritis. Tonight, we have got something extra special. We've got the lovely Dr. Gwen Covey-Crump joining us because we're going to be talking about breakthrough pain. But first of all, I'd like to say thank you to our sponsors. So thank you very much to Animal Care, who are sponsoring this live event. They are the manufacturers of Daxocoxib, which is a new non-steroidal that's come out that has a week-long duration of action. So it's a new tool in the toolbox. And one of the things that we want to talk about where it fits in is cases of breakthrough pain. Is this an answer to these situations? So first of all, I'm going to let Gwen introduce herself, and then we're going to crack on for quite a structured talk tonight. Gwen, take it away.
My name's Gwen Covey-Crump. I am a specialist in anaesthesia and analgesia, which means anaesthetics and pain management. I run a pain clinic for a referral centre, Langford Vets, and they're near Bristol. And I spend, when I'm not working, I spend also my time doing other pain management stuff and talks and maybe supporting Hannah a bit in some of what she does with Cam. And then I walk my dog. And at the moment, that's about all my life. That's about my life description at the moment. Still not feeling out much post-pandemic.
Now, me and Gwen have been friends for years. She was an absolute pillar to me at the beginning, and she wrote me the most wonderful email when I first got interested in this, with loads of references, loads of resources, and since then she's been just like my absolute bum chum. And we work together with our practice trainings. So if you ever want to involve your practice in a CAM practice training event, you will see do working together. So anyway, let's crack on. What we're going to do today is we're going to have, as I say, quite a structured approach, not my normal style. We're still going to be informal, but we're going to try and give you a much better understanding about this term breakthrough pain. So I'm going to give you the actual description of what it is according to the WSAVA, so that's the World Small Animal Veterinary Association. Breakthrough pain may occur with all painful conditions, e.g. arthritis. It is defined as an abrupt, short-lived and intense pain that breaks through the analgesia that controls the pain. The analgesic protocol should be reassessed by careful examination and observation to ensure that there is no new underlying problem causing pain. Veterinarians may be unaware of the occurrence of breakthrough pain in patients with persistent pain unless specific questions are asked of the client. So what we then did is have a look around. What kind of information is there regarding the prevalence of breakthrough pain? And unfortunately, there are not figures available in dogs. We don't have that data. But when we look across to the human sector, 16 to 95% of humans with persistent pain conditions will experience breakthrough pain. So this is really significant. This pain is severe or excruciating and of rapid onset, which can disable or even immobilize the patient. So we're going to stop here and just have a little bit of a chat about our experiences of breakthrough pain, because I must admit it's not something that I ever got taught, and it wasn't something that I was really in my syllabus, and it's only with my journey into arthritis have I become more aware of it. How did you kind of come to understand more about breakthrough pain?
I think actually it's from my own personal experience, because I have chronic pain, and because I've trained as an anaesthetist, I know a little bit more about pain than the average vet, and so I started to look into my own pain and got quite frustrated actually at times with my doctor's ability to manage my pain, and realized that I needed to manage it myself. And so things like breakthrough pain became obvious to me quite an early stage, where I was given quite a lot of pain relief to take, some of which is to take all the time, and others to take just when my pain's really bad. And then I realized, well, that's breakthrough pain, isn't it? Because I've got this baseline and pain relief, and then I've got this extra pain relief. Unfortunately, the extra pain relief just makes me really dopey. So of course I don't take it. But the thing that really strikes me is that as a human, if my breakthrough pain is causing me a problem, I can go and take an extra tablet. Whereas our patients, our dogs, our pets, they can't say, I'm feeling a bit sore today, Mum. Please, can you give me an extra whatever pill you've got for breakthrough pain, because I'm a little bit sore. We have to, as pet owners, actually recognize that in our dogs, and that's what's really hard. And so of our patients, a lot of our pets are really suffering this on a regular basis, and we don't even realize it.
Yes.
And whereas a human would just, your partner has breakthrough pain, they'll moan about it. My poor sister-in-law was saying to my brother at the weekend, which ouchie is it now?
Yeah.
We're only allowed one more ouchie today.
No, it's true. It's true.
Has chronic pain.
I think this might help bring it into context for a lot of people. David Dykes, brilliant person who's been on here before many times. And it was just so obvious when he said, well, actually, the times that you see these dogs as a vet, that's when they're having a breakthrough. Yeah. That's when they're having an acute flare. And I was just like, oh my God, the penny dropped. Because dogs are incredible at coping. They will get on with it to the best of their ability. Many reasons why people believe this is so. Me and Kathy were having a chat, Kathy Murphy, the other day, and both of us really feel that if you don't know that there's an alternative, what are you going to do? Yeah, get on with it. So dogs are really good at getting on with it. So why do we see these sudden appearances of pain? And the owners go, oh, he's not been like it before. He's suddenly got this pain state. And we're like, actually, he's been there. He's having a flare. And that's why you're coming to see me. So that was kind of quite oh, yeah, that makes sense. And then another thing that I read a few years ago was a human paper about how doctors have a slightly different strategy to us vets, where they put people on a baseline, but they give them an acute flare plan. And they also, your level of pain management to a different level, a greater understanding. So hopefully those two things that I've just said have been a little bit of a light bulb moment. So this is actually really prevalent. So let's now just go back to my crib sheet, being super organized that we are at the moment. There was a phrase I really wanted to bring in now. And it was basically, we need to reconceptualize osteoarthritis as being acute on chronic symptomatic condition. And I think that's a really big take home, guys. I want you to go away and not just be talking about it being chronic pain. I want you to understand that osteoarthritis is an acute on chronic. So you're going to see breakthroughs. And even when a dog is on a very good pain management plan, they're still going to happen, aren't they, Gwen?
Mm-hmm. And why is that then? So we've got reasons why we think this happens, haven't we? And actually a lot of this is brought from the human.
Yeah, side. Exactly. Do you want to go for it?
Yeah, well, Hannah's done an awful lot of work for today, and she's great structure. So she's looked into what's said in the human literature, which is amazing, because I think most of what we do in the veterinary field is based on what has gone before in the human field, and then we adapt it and improve on it, hopefully, for our animals that we're treating as vets. And there's 3 recognized subtypes of breakthrough pain recognized in humans. First is incident, which, as you can imagine, is sort of associated with a trauma or doing too much gardening, in my case, or lifting or twisting, lifting a slightly heavy dog in the clinics without getting someone to help me. So that will be incident-related breakthrough pain. Then the next one is idiopathic. So this is where we don't really know what the underlying cause is. It's sort of, we always say idiopathic is a diagnosis by exclusion. So we've ruled out other causes. We've got to think about other diseases the animal might have alongside the osteoarthritis and whether that's contributing. And then obviously disease progression comes in here somewhere as well. And then the third category, which is my favorite one, because I like pharmacology, is end of dose failure. So this is talking about the medications that you're giving your dog and the frequency of the dosing, whether it's being given at the same time each day or week, exactly as your vet's asked you to give it, with food or without food. And And this is really related to making sure that owners understand how the medication should be given, and the fact that you want to try and give it at the same time every day and things like that. Otherwise, the dog effectively runs out of pain relief. And so that's what we call end of dose failure. And that can also happen because a particular dog metabolizes that drug a bit quicker than another one. So it actually clears that drug from the body a bit quicker than another dog. And so those are some of the things that we have to try and work out how to resolve as vets and detect that end of dose failure, breakthrough pain.
Yeah, and you were me and Gwen chat a lot, and I can remember you saying to me that quite often when somebody comes to your referral pain clinic, it's not that you're bringing out the magic drug. You're actually going, right, well, what are we on? Are we on the right dose at the right interval? Do they work well together? Have we got too much on board? And often you're rejigging and really stressing the importance of the intervals. And now I know that I'm an airhead, like proper airhead, and it'll be, oh, I'm supposed to give that at 8 a.m. Oh, it's 12. Okay, well, I'll give it now. And I know that's my personality type because I'm just such a busy bee. But having somebody that's going, actually, before we start trying to chuck more in, let's look at what you've got and whether you're using it appropriately or not. But we're going to come back to that later.
Yeah, we'll come back to that because we could talk about that all night.
We've got quite a lot to cover. We're trying to be 45 minutes today, aren't we? Because we've got tomorrow night. We do not want to burn you out. So just to make sure that we're not biased, I know my focus is very much musculoskeletal pain, but breakthrough pain does happen in other systems as well. So you can have visceral, which is your like internal organs, that's pancreatic pain, kidney pain, liver pain, etc. Somatic is the external system, so that's the outer part of the body. Neuropathic, so your nervous system, that can actually also generate pain, and you can get mixed bags. So this doesn't just apply to osteoarthritis. It doesn't just apply to musculoskeletal. This can happen in different areas as well. And then when you look at those causal factors and we're trying to work out, well, okay, we know what can cause it. How can we twist that so that we can start thinking about what we can do about it? And that kind of fits quite nicely into different categories. Owner compliance, and this is why we're talking to you guys, because you are the key. You are the people that are going to make this happen. You are the people that are going to stop these acute flares. Amanda asks, are acute flares and breakthrough pain the same? Acute flares fit within breakthrough pain. Breakthrough pain is more of an umbrella term. So breakthrough pain is any situation where the analgesic protocol we've got in place is not sufficient. And an acute flare is often linked to a trigger. So we'll talk about that in a minute. So areas that we can really make a difference with breakthrough pain is owner compliance, because that can really affect incidents. So these triggers, these situations that cause a breakthrough, such as running down the garden chasing a cat, running up a tree, getting a squirrel, throwing balls, frisbees, jumping out the back of the car, sliding on the laminate floor, all of these things that Cam is really, really passionate about. They are potential triggers for acute flares. And you as the owner have amazing ability to influence that. But also, as Gwen was saying, the end of dose plasma levels. You're the doser, you're the medicator, you're the person that's going to be giving these potentially life-changing medications at the dose, the frequency, the regularity, etc. And other things that can influence is disease progression, which is a little bit more out of our control. But going back to lifestyle changes, whether we haven't got the data in dogs yet, but it's clinically logical that if we stop having these disease progression induced by triggers of trips, slips, falls, stumbles, we should therefore slow the disease. So, right, we've already talked about how in humans it's a verbal thing. We now have to be the animal's advocate. And how can we do this, Gwen? How can we actually pick up on breakthrough pain?
Keeping a diary. It's my favourite one. So I think you've got a very small amount of time with the vet usually, and you're often taking your pet to the vet at a point where you think pain is a problem. And if you can provide them with a diary and show a pattern that you've noticed, one that's going to prompt you to go to the vet sooner, because you'll recognize it sooner. And the other thing is it really helps the vet see it and believe you. Hopefully they would believe you anyway. But I find it really helpful when a client has actually monitored their dog's pain and is able to say it usually happens at about 3 o'clock in the afternoon, just before he has his next dose.
Yeah.
Or it happens, he wakes me up at 5 a.m. And that's classically another favourite topic of mine, because his gabapentin's worn out. And he wakes me up at 5 a.m. and it happens every morning. And so what I'm trying to do is try and sort out those timings of drugs. But keeping a diary is really helpful. Working with your vet or vet nurse to look at some sort of monitoring tools. So pain scoring tools that we can use for that either vets can use or get you to use at home.
Yeah.
And there's a particularly powerful one. I think, are we going to talk about pain scoring?
Probably won't have time today.
No, probably tomorrow. We'll talk about it tomorrow. But there are some quite useful, quite powerful ones, which also are a really good tool for helping you to recognise the pain in the first place. And I often talk to vets, because vets say to me, how do I get my clients to recognise that their dog's in pain? Because if they can't even recognise the dog's in pain, how are we going to monitor an improvement or worsen? Yeah, exactly. And there's one particular pain scoring which is really good for actually talking through what your dog does normally, or what your dog used to do and has stopped doing. And we can work towards trying to get them doing it again. So it becomes not only a recognition of the problem, it's a target for improvement. Yeah. And that really helps to engage you and make you more empowered to manage the problem.
Which one is that one?
The CSOMs, the client-specific outcome measures. So basically we create a pain score based on what you and your dog does and what you've noticed. So it's a really personalized.
Yeah, I love them. I love them. I can remember, this is just another Hannah anecdote. I had an owner phone me up after one of my home visits. He went, oh my God, the dog is doing the stairs again. And I was like, yay, no.
Don't let him do the stairs.
No. And I felt like such a party pooper. Yeah. I was like, that's great, but no. So I think for me, in the same category, I'd probably go one step behind you and say, guys, just be aware it exists. I think I definitely was more of the mindset, well, he's on pain relief, so that's going to be fine. It's going to be fine. He's on pain relief. That's going to just work. Why wouldn't it? And I think having awareness that it exists, and nothing comes with a promise. It might come with a 12-hour promise instead of 24s. So having awareness that this exists, being observant, and being able to get that information across to your vet, and having maybe even drop the word in and say, I'm 6 o'clock. I'm wondering if there's some breakthrough pain there. And just try and start the conversation, because in honesty, I don't think it's very well known. And I know that they did a survey amongst vets of how many of you understand about breakthrough pain, and it was not well recognized. So it's quite a new topic. So if you feel that we're hitting a nerve, we've said something, talk to your vet, maybe even send them to this live. Be a good idea. But even drop in, I think this might be breakthrough. Something's not right. The pain medication we're using isn't working for the duration that we'd like it to.
Yeah, because I think that lack of recognition is a real problem, because if you take your dog back to the vet because you've noticed he's painful again, or you're increasingly noticing he's painful, and then he gets a bit better, and then he gets a bit worse again and a bit better, and you go back to the vet and they start your dog on another drug, because possibly they haven't recognized that actually what you need is a rescue drug rather than another drug to take all the time. And quite often I see in the pain clinic dogs coming in on like 5 different medications for pain, and I have to really start paring back and refining, because the vet only gets this snapshot in time of how your dog is, and you present your dog to them when it's bad. So the vet's going to go, oh yes, he's painful, we need to introduce some more pain relief. So it's really absolutely your job, no pressure, to actually notice that it's intermittent and it breaks through rather than it's all the time, and would have a discussion with your vet, because it is possible that your vet can explain actually he is a lot worse. We do need to start another medication long term. But you need to have that conversation with them and not rely on them to just have X-ray vision and kind of know exactly what your dog is doing, because you're the one who sees it at home every day.
Yeah, and I think, again, it goes back to owner education. So one of the areas on our crib sheet, 3 areas that can be actioned against, and that's owner compliance, progression of the disease, and owner education. So we're talking very much about owner education and empowerment. And I think being aware that you can do short-term adjunct treatment is quite new to people as well. As a first opinion practitioner, the way that the system is, I don't think it allows us to do that. And I think that's why arthritis clinics in practice, where you've got a passionate vet, a passionate nurse, ideally a passionate receptionist as well. That's called the OAA team. If you want to know more about it, please get in touch. If you have that passionate vet that has given a little bit more time, they will be able to say, right, this is your baseline, and this is your acute flare management plan. And you need to remember, whenever we have an acute flare, try and work out what the trigger was, because we don't want to keep having acute flares. And the only way we're going to prevent them is if we work out what the triggers are, so that we can start avoiding them. But that takes time. And that's sadly lacking in practice at the moment. So there you go. Something I do also want to mention about this whole breakthrough pain is there's a real tendency when you've got a dog that comes into your clinic and is an osteoarthritis sufferer, and the owner describes a deterioration in pain state, you instantly go, oh, it's the arthritis, when actually it might not be. And a real classic one for me, which really taught me this the hard way, was a lovely dog called Buttons, severe arthritis, chocolate Labrador, everywhere. And when she had a real downturn, we assumed it was the progression of the arthritis, or she had stumbled over the patio or something. She got an ear infection. So she had an acute pain on top of her chronic pain, but it was a comorbidity. It wasn't to do with the primary disease. This was an additional. Her brain is still perceiving chronic and acute. It's just like so.
And her brain is probably extra sensitive to that new pain as well.
Yeah.
So it's more painful than it would normally be.
Yeah, exactly. So we've got to make sure, not only owner and vet, that we reassess these dogs. We don't just take that assumption, oh, he's just deteriorated. We still need to do a full clinical exam. We need to look at dentistry. We need to look at ears. We need to palpate the abdomen. We need to be making sure, like it could be a septic joint. That's an acute on chronic. So we need to palpate these joints and have a proper look. And owners need to be receptive that might require further investigations. It might be a longer consult. It might be a blood sample. It might be a sedated to examine. So definitely a team approach to that, isn't it?
And do you know another really common cause, I think, sorry, forgive me if I'm jumping ahead, something that I see an awful lot is older patients that have a little bit of the cognitive dysfunction, senile dementia, that we know dogs have. If they get an infection, and this is the same in humans, if a person with dementia gets an infection, they get acutely worse cognitively. So they are less able to make decisions and things like that. And the same happens to dogs. And what it looks like is that the dog's deteriorating and not coping.
Yeah.
And actually its arthritis hasn't progressed. It's just got an infection and its dementia has got worse.
Right.
Clear up the infection and it's back to being bright and bouncy, elderly, well-controlled arthritis sufferer.
Yeah.
It's happened so many times. And I'm now getting to the stage where all of my elderly dogs, I want to rule out infection.
Yeah.
Like things like urinary tract infections, which are quite easy to test for, without spending too much money.
I totally agree. And now, do you remember, it was about 2-3 years ago, we got into the Sunday paper, didn't we? Stop putting these dogs to sleep too soon, because I think there is a tendency for us to go, oh, he's on the decline, really bad decline now. And it's really hard for vets because there is a bit of a gamble. You're just about to say to this heartbroken person that's dealing with potential grief around the corner, let's just try something else. And what happens if it doesn't work? and you've dragged out that most difficult time. So again, it's a team approach. And I will always remember the lovely Flossie. So she was a border collie, and I worked very well with her owner, Izzy. And there was multiple times that we were like, are we here yet? And we'd have a very frank conversation where I say, I can't promise you that this is going to work, but can we hang out for 5 to 7 days and see if we come out the other side? And she bounced back at least 8 to 10 times.
And then you've got the roller coaster to deal with.
It's hard.
I've just had some, much loved long-term clients. We've had to say goodbye to their dog, and it's been such a roller coaster the last 3 months. It's very, very heartbreaking for the vet as well, actually.
No, I totally agree. So if anybody ever tells me that arthritis is boring, go away. Because it's not. It's ridiculously complicated. It's emotionally debilitating. It's financially draining. It is such a complex disease that we need to be putting a lot more energy into. I'm just going to kind of push us forward because we're already at 26 minutes. And I just want to talk about incident more. So we're going to go back to those categories that me and Gwen originally talked about, which was incident, idiopathic, and endodose failure. So let's start with incident. Again, there is very little in the literature to help us with dogs, but there is a paper looking at humans. And this was quite a good paper to kind of get the message out there. So there's 67 participants in this study, and 30, they all kept a diary, as Gwen was saying, of how their pain felt over that month. And 30 participants in that period of time experienced 54 flare-ups. So that was the pain localized to their joint deteriorated dramatically. And they reported sharp pain, throbbing, stabbing, burning pain, swelling, limping, stiffness, inability to do their normal activities. And in a lot of the cases, they'd had a high loading physical activity precede these events within the previous 48 hours. So this is why, and I got stumbled then. This is why keeping a diary and trying to work out what these triggers are is really important. And this is why Cam talks about footballs, balls, ball chuckers, frisbees, jumping back car stairs, because how great would it be if you changed the lifestyle and you stop having so many flares so you can reduce your medication and slow the progression? So the problem is, isn't it, that study is people talking to us, whereas we've already said we are the eyes and ears for our dogs, so we have to be more observant. So think diary, think CSOMs, client-specific outcome measures, other clinical metrology instruments, which we've talked about before. Right, where are we at? We're kind of getting there. Oh, right. So management strategies. So having already pretty much covered this in what I've just said, how are we going to try and prevent these breakthroughs? I've just said trigger avoidance. I've mentioned that, do we have an acute flare plan in your back pocket for when it's going to happen? You know what you're going to do, which is something that we do in other diseases. If we've got a diabetic, we have the ability to deal with a hypovolemic crisis. If we have an epileptic, we have the ability to deal with an epileptic seizure on top of their baseline meds. It's not actually out of range that we could do the same with this. But another thing is longer term therapy aimed at modifying the underlying disease. And that's where should we step into pharmaceuticals? Do you want to go that direction? Because we're on the verge of insufficient dosing, frequency, timing, etc.
Yeah. So you're talking about using certain analgesics to try and modify underlying disease process. Is that what you mean?
Yeah. So the fact that let's use non-steroidals because that's the logical foundational intervention. And there's a real drive to people using it as little as possible, when actually the data doesn't support that, does it?
No. So technically, non-steroidals are not considered disease-modifying drugs. Those only come into very specific, specialized drugs. But what we're trying to do with anti-inflammatories, and to use them in a dog that has a disease like osteoarthritis that's not cured, and is lifelong. Most dogs will get to a stage where they really need non-steroidals longer term, all the time, not just as and when, because really this disease process is causing a constant pain stimulus to be sent up the nerves to the spinal cord, which is basically the central highway for taking pain information either up to the brain or changing the way pain is processed. And the more we trigger that system, and Hannah can explain this much better than me, the more we trigger that system with this pain impulse coming from the inflamed joint, the more we sensitize and wind up and make those nerves in the spinal cord really angry. Yeah. So that then amplifies pain. So even if we're not actually, so there is also the keeping inflammation down, which is a second point, but there is actually a good reason to keep that pain at bay in the long term, to stop those spinal cord nerves getting angry. And it's really hard to reverse them once they get angry, to calm them down.
No, exactly.
And if we're using pain relief all the time at an appropriate level, monitoring our patients, monitoring your pet for any side effects that may occur, which are thankfully really rare, then we will stop that continuously making those nerves get angry, which is a really poor way of describing it. But
no, do you know, okay, I'm going to give you my ridiculous. This is Hannah's ridiculous brain. It works really well. I always think of National Lampoons when I see it, because I see his house with all the light bulbs, and I just see pain being created in the periphery. Is me giving him boxes more of light bulbs, and he's just going to coat his house, and he's going to keep going, and then they're there, and they just go, don't it? You remember when he flips the switch and the whole light goes, and I think people forget that the nervous system can remodel.
It rewires itself, basically. It rewires it. We can't go into the detail of why this happens, because at face value it seems pointless, but it rewires itself to turn up the volume on your amplifier that you plug your bass guitar into. Basically turn up the gain, turn up the volume, make everything louder as far as the brain's concerned. So the brain is then perceived to be worse than it really needs to be perceived. So that's what happens if we don't control these triggers, because every time we don't control these flares or this breakthrough pain. So every time you get some breakthrough pain, that process is allowed to happen. A little bit of wind up, a little bit of irritation.
Yeah.
And then there's also
light bulbs.
Yeah. And then there's also the fact of keeping inflammation down at the joint level. So I feel a bit out of date as the evidence of whether using non-steroidals consistently can actually reduce the speed at which the joint deteriorates. But the joint deteriorates because of inflammatory chemicals that are being produced within the joint. Mm-hmm. And basically the cells produce chemicals that attack the cells, and even the bone underneath the cartilage starts to get damaged. And that is a chronic inflammatory process. So it makes sense that by controlling inflammation with non-steroidal anti-inflammatories, that we can keep that process subdued.
Yeah, absolutely. And there are other interventions that we're using. So the talk is about pharmaceuticals, because one of the things that we know point blank is pharmaceuticals is the foundational intervention. It's easy to administer, it's cost effective, it's got safety data, efficiency data, efficacy data. But there are other interventions. So there's our intra-articular, there's the modalities such as laser, extracorporeal shockwave. There's other things that can work on inflammation as well. But that's not the topic tonight. But what we're trying to get across is that there is a definite fear of using medication, when actually a lot of the literature is saying, wait a minute, if we really want to stop the wind up, this central sensitization, this National Lampoon box of bulb giving, then actually having a anti-inflammatory in the background for longer periods of times being dosed appropriately is going to be more effective at controlling these flares. But what we do have is a situation where people are very in fear of using medication. That's been really pointed out to us with Zoe Belshaw's work. Now, Zoe, legend, she is brilliant. And she did a brilliant live with us last year, maybe. She did an incredible PhD paper looking at people's attitudes towards using medications, be it owner, be it vet nurse. And some really potent things came out of it. And one of them, which no one's going to like to hear, is we became so aware of how bad we are at detecting pain. And we said this right at the beginning, dogs cope very, very well. But not only were owners really aware that they actually, once educated, weren't good at detecting and monitoring pain, but also the veterinary professionals in that stressed environment of the clinic were struggling to pick up cases of pain. So that, I think, is really quite important, because we've got this painful condition that if we leave it alone and it does its own thing, it's likely to become centrally sensitized, and more pain will be perceived in the brain than is actually created in the periphery. And we're admitting to ourselves that we're not very good at detecting pain. This is a very bad scenario to be in. Okay, therefore, do we have to be a bit more belt and braces with our approach? Should we be more confident in using medication in a more, I don't want to say blanket because that's not the right word, but in a more structured, confident way, rather than going, we'll use it as and when? And that's where a big discussion needs to be had, isn't it? Because that really relies on the owner and the veterinary professional being so good at detecting pain to know when to use it. Is that right?
Yeah, I agree. I think I do have some colleagues who are quite anti my approach. If the animal can tolerate it, there should be a baseline non-steroidal in place if they have osteoarthritis beyond a certain point. There's an awful lot else can be done to try and keep that inflammation at bay, such as the lifestyle changes, avoidance of triggers, introducing some things like physiotherapy and other therapies. Non-steroidals is not the only way to control inflammation, and also that becomes really important when you've got a dog that can't tolerate non-steroidals. But it's that the sort of intermittent use, just throwing a little bit of a non-steroidal at the dog for 3 or 5 days and then stopping, and then just throwing it at another 3 or 5 days when it seems to be bad again. Totally reliant on the owner noticing that there's a problem. And also, each time you're just letting that inflammation, that amplification build up again. And so if as an owner, you are super, super switched on to how your dog is and what you think pain looks like, and this really needs to be done in sort of partnership with your vet nurse team, then you can discuss with your vet the idea of possibly reducing the dose, perhaps, but still trying to provide that sort of everyday cover. But even reducing the dose, we've got evidence, studies that have been conducted to show that you probably can't reduce the dose of non-steroidals beyond about 80%. So reducing by 15 to 20% before you get quite a lot of dogs then dropping out, getting breakthrough pain. And this is, and again, as I said, it's totally reliant on you noticing that pain when it happens.
And being confident that that's what you're seeing. Because I know that we both have the imposter syndrome, don't we? And am I seeing that? Is that really there? Or is it there tomorrow? Have I seen this consecutively? Is it worth mentioning to the vet? Should I book another appointment? So many demons come into your head to influence whether you actually pipe up and say something, on top of whether you've even noticed it. So I think a lot more education and empowerment about that, but also being honest. If you don't have those skills, if you know that you're not very good, or it's been shown that you're struggling to be aware, then being in fear of using long-term medication should drop, in my opinion. And let's talk about the fear and what's driving this fear. So when we look at adverse events to non-steroidals, they're actually not very high. But if you were to listen online, you would think that every second dog has a reaction. And it really isn't that case. And I'm just going to hark back to a ridiculous survey that I did about 5 years ago that I felt was quite potent. So we have vet forums, the same as you guys have your dog forums. And I put a message out. I said, right, guys, know what you know about non-steroidals and adverse event risk. would you put your own dog on a non-steroidal? And 100% of vets, 200 vets replied and went, 100%, of course I would. So if we're seeing these adverse events so often, surely we wouldn't be wishing to put our beloveds through the same risk. And I have no problem prescribing an anti-inflammatory. I'm very confident. Yes, there are adverse events. They can happen. The majority, the severe, massive majority, is just a gentle gut upset that is transient and they resolve. However, yes, there can be, but that's the same with all medications. And I always hark back to people saying, what's the worst side effect when you're in pain? It's no effect. You know, if you're in such severe pain and you're being given loads of things that don't work, you're like, I'm still in pain. That is a side effect to consider. So just running through some of the adverse events, you can get some soft feces, you can get some decreased appetite, you might get some blood in the feces, but these generally are like 1 in 100, 1 in 1,000. So they're really not considered hugely common. Lethargy, 1 in 10,000. You might have a slight liver raise. That's normally about 1 in 100. So they're really not as high as you think. And when they've looked at these studies of adverse events, if you're going to have one, you tend to have them quite early, don't you, Gwen?
Yeah, the severe ones, yeah, for sure. Yeah, and things like soft feces and vomiting, it often happens within the first 3 weeks. The problem with that particular side effect, I always think, is dogs eat rubbish. And we never know whether they've got their soft feces and vomiting because they've eaten something disgusting. But we always blame it on the non-steroidal. So the hope is that we then, get them sorted out and then put them back, try putting them back on it. But that's probably the most common one, and they do tend to happen fairly early on. And certainly the severe adverse events also tend to happen early on if they're going to happen.
I can actually remember the day when I actually had the courage to say to an owner, I don't know if this is actually non-steroidal related. So what I'd like us to do is have 7 to 10 days off, and then we're going to reintroduce it.
Yeah.
And I was waiting for them to go, are you joking me? No. And they were like, oh, cool. Okay. And I was like, because really think about it, bouts of diarrhea can happen for all different reasons. Let's just make sure that this isn't a coincidence. And sure enough, 7 to 10 days rest, introducing it again, the dog was fine on it. And that's happened to me multiple times.
It happens to me a lot.
It's a really difficult conversation to have. You have to.
The other thing I've had is dogs come to me where the vet has taken them off an anti-inflammatory, but actually it was a relatively low risk. Maybe the dog's got a little bit of early chronic kidney disease.
Yeah.
But actually, it's a palliative care case. This dog's got a really severe, painful condition. It's elderly, and that anti-inflammatory was helping its pain so much, and now it's crippled, and the owner wants to put it to sleep because the pain is not controlled. But actually, the risk to that dog, in my opinion, was quite low. And I had you have a frank discussion with the client to say, look, we don't know what level of risk that anti-inflammatories cause for this dog, but I think it's very low. He's in an awful lot of pain, so much so that you're thinking of putting him to sleep. I think we should put him back on this. It's a difficult conversation to have, especially if, and I don't think the vet was wrong to stop that anti-inflammatory. It's just trying to explain to the client that, I don't think the vet was wrong, but actually on balance, having had the discussion, I've got an hour with you instead of the sort of short consult your vet's got with you. Shall we restart it? That's happened to me quite a few times.
Yeah, and I think it just shows again that, and it is going this way. Yet again, today I've heard of another chronic pain clinic that's opening up down in Cornwall, actually. So I think we are beginning to see the need for more time for these cases, because this kind of level of care is going to take more interaction between the vet and the client to uncover these problems, breakthrough pain, and how we're going to best manage it. Just moving on, because I'm just looking at time, we're at 45 minutes now. Do we want to say anything more about the dosing? We've spoken about the fear, and that it's very well known, but when we actually look at the adverse event rate, it's actually quite low. And generally, if there is going to be an adverse event, it's quite early, and generally they're pretty transient and minor. But when we're looking at controlling this pain and trying to prevent central sensitization and this wind up where more pain is perceived than is being created, being confident with our anti-inflammatory use is really important. And that means an initial prescription of not 3 days, but maybe 4 weeks, 12 weeks, consistent dosing, good timings, keep trying to maintain this plasma level for it to have its best effect. And that is probably a good place to kind of maybe even end today, because one of the things that we are talking about is a non-steroidal that is available for 7 days. And that's where our sponsor, Animal Care, has produced a non-steroidal that does have a plasma level that lasts for 7 days. And it's going to be really interesting whether this can potentially reduce these breakthroughs, which we know are prevalent. Can you add any more to that?
I think this new anti-inflammatory is really great. It's got a pharmacology, a pharmaceutical profile, which means it sort of slowly releases this compound that is the anti-inflammatory, and it builds to a steady plane over the course of the first 7 days with the initial loading dose, and then with the subsequent weekly doses that are at half that initial dose, that plasma level is maintained really steady. There are no dips, there are no troughs and peaks, and that is why I think it's going to be so successful, because people who live busy lives and busy households, several kids, 2 full-time, one full-time working person, just getting that daily dose. So a lot of the other anti-inflammatories are daily dosing. One or two of them is actually twice daily dosing. Getting it in on time each day, not forgetting it, making sure you don't double dose it, is quite a stress. And if you forget it, then you immediately, those plasma levels dip. And so you then give it as soon as you remember. But then what time do I give the next dose? Because I don't want to give it too soon, because is that safe? So this new drug has the potential to take away all of that concern, if you're busy and and if you're just taking pills.
And I think exactly. I think it's just another tool in the toolbox. This is what CAM's always trying to do, is basically say to people, there are many options out there. So go to your vet with an open mind. Be able to be receptive to, be it pharmaceutical, be it modality-based, be it lifestyle-based, be it exercise-based, be it weight control-based. When we did our live yesterday with Dr. Jennifer Brown, we started off the live saying, well, there's actually very little information about digital OA. Doom and gloom. And then by the end of the Facebook Live, we're like, oh my God, there is so much that we can do to help this condition. And I think that's what I really want people to go away with. There are tools out there.
Yeah.
Something to leave you thinking about, though, guys, is what I said a number of times. Nothing comes with a promise. And your vet is trying to give you the best opportunity. They're going, I'm going to look at the pros, I'm going to look at the cons, I'm going to make a decision based on the dog that's in front of me. And again, I'm just going to drop Zoe Belshaw's work. She uses BRAN: benefits, risks, alternatives, what if I do nothing? And that's what her brain does when she's prescribing. I love it. Benefits, risks, alternatives, what if I do nothing? So I think you have to remember that's what your vet is trying to do for you. But a study that I'm just going to read off here, this was, I think there was 29 dogs on a non-steroidal study, and they were consistently dosed appropriately to the recommended dosing level. But 6 out of the 29 dogs did drop out because they had uncontrolled pain episodes. So even when you've got a drug that's got loads of evidence, loads of safety data, loads of efficacy data, your dog is unique and you are its advocate. And if you don't think that it's giving you sufficient pain control, either at any time or it breaks through at certain times, talk to your vet, because there's going to be other options out there. Right, let me just see if there's, oh my God, because I've had a crib sheet, I've not seen everybody's writing. So sorry, guys. I've recently noticed a massive change where, oh, here we go. He's on pain relief for arthritis in spine. How he's recently been less tolerant of dogs, even though his walks are fine. So that would be a classic case of going back to your vet. We've got something called Suspicion of Chronic Pain PDF. You can download that. All the things that you see and are making you concerned, because you've written them down, you hand them over in that consult. It's so quick to take what you're seeing and start acting on it. Whereas when you come in and go, he does this and he did that and he might have done this, I'm not really sure. Get it written down. Make the most out of that consult. Has Lynn already put it there? Oh, no, she's on the good day, bad day. Don't check out Lynn. She's so on it.
That's the most common thing I see coming into my pain clinic, is that he started being less tolerant with other dogs, or more snappy with the children, or this sort of thing, and that's what's triggered the referral. Because then they think it's to do with pain, and the vet doesn't know what more to do. In the case for me, I'm getting these referrals for dogs that have difficult to manage pain, whereas your vet is likely to be able to look at the cause of that, and that is a really common sign that there's pain involved if they become more reactive.
More reactive behaviorally, definitely. I love this. This makes me really happy, because a lot of blood, sweat and tears goes into CAM. So to know that it's actually making a difference is, yes, high five, if we like. Is there a clear way to tell the difference between breakthrough pain and an injury? That would be clinical exam. Something that we didn't cover, which I think is really fascinating. When you look at the literature in humans about breakthrough pain, acute flares, the owner of the pain, the human, is able to describe that it's coming from the joint that is affected. So we're talking about a flare of the osteoarthritis in that joint, because what they describe, the location. Problem with dogs, they don't have the ability to do that. So have we got co-morbid disease in that it's a compensatory problem? Is it a myofascial problem? Is it a tendinopathy secondary to the OA, or consequent to the concurrent with the OA? So sometimes when we're looking at dogs and their sudden deteriorations and we classify them as acute flare, in many ways it's not technically correct. It's more a breakthrough pain. Something's creating pain. It might not be the disease. Is that fair?
Yeah, absolutely.
Cool. What's this one? I've noticed soda turns into a nagging, back-chatting nag. What? Well, that's Kaz. Kaz is amazing. She comes to all of these. Has a UTI, doesn't use the dog door without telling me loudly in the middle of the night, when normally she's fine. See, behaviour again. Great. What's this one?
And she was also specifically talking about the UTI makes her worse. Remember, that's probably from what we were talking about earlier.
Yes, another reason to take a urine sample into the vet's, guys, not just to look at kidney function, but just to check that there isn't anything else underlying. My girl loves to trot on even surfaces. I don't know how far is too far. I've never seen it cause a flare-up, but have never gone further than about a mile. I worry because he doesn't get much exercise on a regular basis. I will tell you that we've got a nice section in the owner CAM Essentials course about exercise and things that you can vary, frequency, time of the day, terrain, activities, and that will give you some inspiration to maybe vary up what you do. So they're not necessarily doing more, they're just doing something different. But the only way that you would know is to increment slowly and have a look at the effect, document it, diarise it, look at what your potential trigger was. So if you've upped the exercise by 10 minutes and then, a few days later, you're like, a bit stiff, too much. Can you add anything to that, Gwen?
No, I think, the only thing I would say is I think almost universally people assume dogs need more exercise than they really do.
Yeah.
I think what we're giving dogs too little of mostly is the mental exercise they need. And actually running and lots of walking is, they don't need loads of cardiovascular exercise, for example. I'm not a physiologist, but it depends on the breed as well.
Yeah, definitely. I've got to show this because this makes me very happy. Another thumbs up for Cam. Yay! Good. This is what we're here for.
I don't even have time to read that.
Oh, sorry. She just basically said she had the confidence from what she was reading through CAM to actually, change practice, speak to a different vet, pipe up and be her dog's advocate. So that makes us really happy. Don't want you changing vets, obviously, but to have the confidence to say, no, I really need more is great. Oh, here we go. This is one for you, Gwen. Amantadine. Your views. I know it is in the breakthrough pain toolbox as an option.
I love it. I use it a lot. I think it's a very, dare to say the word, safe medication. It's got very few side effects, providing you dose it appropriately. If you slightly overdose, your dog's just maybe going to get a bit of agitation or sleeplessness. And it can be dosed once or twice a day. It takes 2 to 3 weeks to really kick in, but it's what we call an antihyperalgesic. So it's taking back that irritation, pain, wind up I was talking about earlier. It's not a pain relief in its own right. So we don't use it on its own. But yeah, I do think it is brilliant. There's also another one very similar sounding called memantine, which is also, it does the same thing. It's just a slightly different dose.
Here's an impromptu question for you. We haven't planned this at all. So if you had a dog where the owner said, no, he's been really, really good for the last 6 months. He's deteriorated literally in the last week, but I do know that he chased a rabbit around a field on Sunday. What would you go for compared to somebody that said, actually, I know there's been quite a while now that he hasn't been himself, and the last 4 to 6 weeks we've seen a deterioration, and it's consistently there. Do you have different?
Yeah, well, I think if it looks like the animals had poorly controlled pain for quite a while, then I wouldn't hesitate to put them on one of these drugs. But if we can identify a trigger, then it makes sense to have a period of a couple of weeks maybe of stabilization to see if it improves before we then start another drug. Because a lot of vets feel, and originally I would teach as well, that you only need to use amantadine for 3 weeks. But actually that's technically that's how long it might take to take back this pain wind up. But actually the arthritis is not gone away. So it will just come back again. So quite often the dogs end up on it long term. And then it's quite often difficult to then take it away to see if the animal really needs it. So we try to rule out triggers or flares before we start a new drug. If it's been identified, and
I think that's really important, because going back to being a first opinion practitioner, amantadine is expensive. And that's quite a big input that the owner is going to put financially into a case. And if we can have a conversation and say, look, right, let's really drill down. Is this a spike? Have we got a trigger? Can we get away with using cold compresses, paracetamol, restricted exercise, lots of distraction? Let's spend 7 to 10 days in close contact. Are we coming out the other side? Yeah, brilliant. And we can go back to our baseline management. But again, time in consults can often mean the prescription of another layer that might not actually be needed consistently. But it's time.
Amantadine's not your quick fix thing. It's to be used for long-term pain management. So
yeah. What's this one? It's been so helpful. I wish I to list your comments about the big benefits of keeping an OA dog on non-steroids long term. My dog has been on the full dose of Meticam for over 3 years, plus amantadine more recently. I've tried unsuccessfully to reduce the dose and follow a multimodal approach with hydrotherapy, laser, and acupuncture. Yes, good. That's what we're trying to do. There is no benefit in us trying to promote, something over another. Multimodal is the way forward, and we just want to open your eyes to what is out there so that you can go and have the right discussion with your vet. Perfect. It's 60 minutes on the dot, which I think is fantastic. We're going to be back tomorrow. We've got the second part of this, which is going to talk about medication a bit more. But please, if you have got your questions, come prepped tomorrow. pose them to us and we will do the best to answer them. Again, I would like to say thank you to our sponsors, Animal Care, who are the creators of Daxocoxib. Yep. And we're very grateful to them for actually giving us the opportunity to talk about this really spoken about situation with OA. So big take home, guys. Yes, it's chronic pain, but should we actually be calling it acute pain or chronic pain more appropriately? Do you want to know anything? Are we done?
No. I think we've got tomorrow as well. Tomorrow. Lots to say tomorrow.
Tomorrow it is. Thanks, Gwen. Love you loads. And we will see you tomorrow, guys. Bye.
Bye.